When you call 911 or when you take a loved one, a family member, you go to the emergency department um, for a traumatic brain injury, you set in motion a complex sequence of events. And today we're just going to talk a little bit about what it is that occurs. We're not going to talk too much, but we are going to describe at least the basics so you understand a little bit. Should this ever happen to you, or if it has happened, so you have at least a little bit of an understanding of all the moving parts, and so you can say, oh, this is what's going to happen next. Now, I do want to stress that everyone's journey through the process of medical treatment and rehabilitation and return to the community is different because, well, every traumatic brain injury is different and your needs are different, but at least the outline, which we're going to get into now, is similar because we have standardized a lot of the procedures over the years since the trauma system has been developed. And there are a lot of similarities, regardless of whether this takes place in the United States and Canada and Europe, Australia, and most of the technologically advanced world. And part of it is because of a lot of conferences, a lot of research and evidence-based medicine, which is something you're going to hear me talk about and touch on throughout. But let's get started. Imagine we have two patients, Dick and Jane. Okay, if Janie has a mild traumatic brain injury, which is judged by the Glasgow Coma Scale, that still is kind of the rule of thumb. Basically, we'll talk about that first. Okay, so if Janie were to slip on the ice, hit her head, and is feeling like a lot of pain, is feeling kind of sick, there are different options available. Most people who have a mild traumatic brain injury will either, they have the option to call EMS, or they can go to urgent care, their doctor, or go to the emergency department. The first thing that would happen is if you choose to call EMS, a dispatcher who is a person who will take calls for 911. Those of you, or 000, 112, just assume there's a lot of similarity here. I just want to stress that. Will ask a series of questions in order to triage the severity of this call versus other emergencies like cardiac arrest or a twisted ankle or whatever else, because there are calls coming in from many different people. And if you're calling from a smartphone or any kind of phone, if it has GPS capabilities in it, it will, if you have enhanced 911, it will give your GPS location and they can find you. But some phones don't have that capability, which is why they ask for the address, because you may be calling for yourself, someone else, or you're not in a system that has that. But almost all modern 911 type systems these are known as public access points or public safety access points where the dispatchers are. Okay. Then once they take the call, they start asking you these series of questions. At the same time, either another dispatcher or the same dispatcher will determine how severe your head injury. If it's mild, they then may dispatch a basic life support ambulance.
My name's Lee Harriott. I've been working at the 911 call center here at Toronto EMS for quite some time now. I've always considered myself a people person growing up. I'm not happy unless I'm helping somebody else find their happiness or help them through a struggle that they're having. I've always felt that I've had a calling towards the helping profession. I've always wanted to find some way that I can use my skills, my knowledge, my drive, my heart to help somebody else in their time of need, when they need help. Even though I find my job one of the most rewarding things that I've ever done, there can be emotional draws on it as well. Listening to that panicked parent because they don't know what's wrong with their young child, or their young child's having difficulty breathing, you can just hear the terror in their voice. And at times, the huge number of emergency calls that we get on a daily basis, it almost feels like it doesn't matter how many ambulances and how many paramedics and how many call takers we have, you could always use that one more to answer that line that's ringing out. There's nothing else that I'd really rather be doing. Having the ability every day to actually make a difference in somebody else's life, for me, that's what it's all about.
Now, basic life support unit is typically staffed by 2 emergency medical technicians, EMTs, here in the States. Now, an EMT has a few hundred hours typically of training. This varies from state to state, okay? The Department of Transportation, Department of Health, and the State Department of Health determines about how much training they have to have. An emergency medical technician, or EMT, typically is the lowest level of training. EMTs know how to take care of basic trauma. They know how to stabilize you, how to get you out of a car, how to assess you for more critical injuries. They know how to do mostly the non-invasive stuff. In some states, they're capable of starting IVs, things like that. But for the most part, they do the basic stuff in the field. But their skills are foundational for more advanced levels. For a minor traumatic brain injury, typically, for a minor fender bender, if you slipped and fell on the steps or whatever, you will get basic life support. But remember, these skills are foundational. They'll handle airway, breathing, circulation. They know how to use an AED. They could use an EpiPen. And as I said, in some places they can start an IV. If you need more advanced care, if you're more seriously hurt, then you would get a paramedic. A paramedic is a step up, and they kind of practice a very limited type of medical practice. They do a lot of doctor type stuff, doctorish kind of things. They can not only start IVs, they can push a lot of the meds they handle in the emergency department. They can intubate. In some states, they're allowed to do rapid sequence intubation, so they can use paralytic drugs. They can intubate. They can give certain anesthetic agents. They can give opiates for pain control. They can give pressors, which raises your blood pressure. So if your blood pressure's down, some states they're even allowed to give blood. They can put chest tubes in again in some states. They can do cricothyrotomy for surgical airways. They can do in-depth assessments to determine where you need to go. They could do a lot of like what you would get in the initial stages of the emergency department, and they have a very close link with an emergency department physician. Basically, the ED physician extends their license to the paramedic. Their supervising physician is granting them that practice of medicine. They follow protocols, a series of sequential steps, and they use their own clinical judgment to decide yes, no, do they need to go to a trauma center, and they work closely with emergency physicians to make these kind of decisions. So a paramedic practices a supervised limited form medical practice in the field, but you call on a paramedic mainly if it's more serious. So it depends on how bad Janie's fall was, and the dispatcher will, based on those questions that they get from a computerized dispatch system and listening to the patient getting their history, and they'll help make the decision, the triage decision, as to whether to dispatch an advanced life support or basic life support. Or Janie could, get somebody to drive her to, the emergency department, wherever. When the ambulance would get there for her, if they send EMTs, they will do an assessment first. Doing the assessment, they figure out, okay, well, it's like maybe she may have hurt her neck, so they may put a C-collar around her neck. They may put her on a backboard, although we don't do this as much as we used to in the past because we found that actually can make things worse unless there are certain protocols that research, evidence-based medicine has said, if we see these things, then we will put the collar on. Otherwise, it's like we could just take you, transport you, like take you to the hospital. We check for blood pressure, breathing, heart rate. Do you have pain? Do you have certain clinical signs that maybe this needs to be a trauma response instead of simply just take you for a general evaluation? All right. So their job is to stabilize and assess you. The paramedics can do more, and they can communicate more with the physician. And usually, if it's the paramedics coming for you, they do a lot more hospital-type treatments. In fact, I'm going to share a video here where you get to see some of the stuff that the paramedics would do for traumatic brain injury. This is from the United Kingdom, as some of these videos will be. But I want you to just get a feel for what the paramedics can do. They can do a lot more.
It's the run-up to Christmas at Air Ambulance Headquarters.
3 take-off checks. Engines both fly.
Yeah, I got it.
Doors and harnesses.
Close the scale.
And Helimed 98 is being scrambled to a rush-hour crash.
Gap in the back.
Yep.
With paramedics Daz and Lee on board, and Dr. Chris.
We've been asked to attend an incident in Goole in East Yorkshire. Reports of a female driving a car who's had a collision with a tanker.
The accident scene is a long way from a major hospital. The team are already planning the patient's journey.
So by road on red from there, you're looking at
That's at least
half an hour on red.
And it's a 10-minute flight.
10-minute flight. So yeah, absolutely. If we're close on it, then I think you definitely go by air.
It looks like if it's plotted right, we should be able to land in the field quite close.
Yeah.
It's there, yeah.
Yeah, so something going on there, isn't there?
Yeah, definitely.
Desk from 9-8, we've got visuals of the scene and looking at that.
Firefighters and ground ambulance crew are already trying to free a woman from the wreckage.
Is the car in the field on that side?
Got the wires on the far side, yeah, looks like it. Yeah, there's a ditch at just the other side of that road.
That might be an embankment as well.
Yeah, got it. Yeah, we'll follow the wires in, mate, and just go in that field there.
Alright.
Landing at night is always risky.
Right, wires just going out underneath us now.
Yeah, we've got a ditch this side of the road.
It's just going to be a bit muddy, guys, I'm afraid.
But Jeff's flying skills ensure a gentle landing.
Hello.
The patient is a woman whose small hatchback was in collision with a tanker.
Hello, mate, you alright? This is Chris, Daz.
Yeah.
How you doing?
She's lost control of the car in there. When you go to open her eyes, it's as if she's pulling her eyes closed, but she's not having any verbal responses.
Was there any history of swerving or anything before?
A bit, yeah.
So with query medical, maybe, possibly before crash, yeah.
Janet Jessup is unresponsive.
Janet, just open your eyes for me. Good lass.
She's showing signs of a major brain injury.
A little bit dilated. Janet, have you any pain anywhere at the minute? In your chest there, in the middle?
I'm just facilitating getting a board here and everything just to get her out.
At the minute she's breathing, a little bit tachypnea. Left pupil looks a little bit sort of bigger than the right one, so we'll have another look.
Absolutely. I don't know if you see, mate, but that is the side of the vehicle.
I think she might have been hit left side of her head.
Her dilated pupils and behaviour are a red flag for the team.
Janet, where's that? Janet, where's that? Janet, just try and relax. Where's that pain? Janet, stay there. I'm just going to disconnect these for a sec. Janet, leave that on, please. Leave that on. Janet, we're going to get you out just now. Janet. Sit still. Janet. It's all right. She's going to have it off. I'll take it off. Janet, take it off. That's fine. I'll just pass you that back a sec. Janet, listen to me. My name's Darren, okay? You've had a car crash. We're going to get you out just now.
Daz wants Janet out of her car as quickly as possible.
We'll help you. We'll assist you. So what we'll try and do is get a bump forward, slide her up the board.
Where she is, the team can't resuscitate her if her condition worsens, and giving blood or intravenous drugs is much harder.
We've got someone at the top that can take C-spine at the top. We'll immobilise her as best we can once she's on. The hardest bit's going to be getting sort of a bum round onto the board, so we're going to have to sort of like get someone in there.
They're trying to keep Janet's back straight, in case she also has a spinal injury. But in her case, speed is of the essence.
Okay, ready, set, move. Okay guys, we're coming out. Okay, so just round onto the board, and then we need someone else in here. Okay, ready, set, move. And then just lay her flat back if we can, like that. Janet, let go of that steering wheel. Let go, please. Janet, let go. Good lass, good lass. Lay her back there, and then we'll just slide her up the board.
Janet's life is in the hands of medics and firefighters, using muscle power to safeguard her spinal cord.
Okay, from head ends. So whoever's got head controls the mood. Move. Yeah. Okay, on you, mate.
On 3.
Yep.
1, 2, 3.
Okay, just rest there a sec.
The tanker's steel bodywork sliced into Janet's car. It's feared her head took some of the impact.
The road tanker was relatively undamaged and significant damage to the vehicle that the lady was driving. Bearing in mind the high impact velocity she sustained, it was a case of plenty of people and quickly and carefully extricate her as fast as we possibly can.
Janet, lay still for me. If you just keep hold of her head at the minute as well. That's perfect. Janet, open your eyes for me. Janet.
I'm not really happy with her level of consciousness.
No, do you want us to prep for RSI? And if you get round the back of the...
Have a quick chat. Janet, I need you to open your eyes. My name's Chris, I'm one of the doctors.
Dr. Chris is trying to assess his patient's level of consciousness on the Glasgow Coma Scale, or GCS. She barely scores.
So eye-opening none. Who are you going to set up for... Kicked up, Lee. I'll do drugs. Yeah. Essentially, at the minute, she's got life-threatening injuries. Yeah. We're going to give her an anaesthetic, put her off to sleep to make her a bit more stable and take her into Hull Royal Infirmary. Okay. She fly with you? Yeah, I believe so, unless something changes.
The team are going to put Janet into an induced coma. It's been proven to reduce the brain damage head injuries can cause.
I'm going to take over at the head end and start giving her some pre-oxygenation.
They're preparing the equipment they need to anaesthetise her here in the road.
So give you a bit of oxygen, my dear, OK?
It's a critical procedure, governed by a precise checklist.
So we'll just go through the checks. So drugs-wise, we're going to give, she's reasonably older, so we're going to give her 100 of fentanyl. Then I want you to give her, she looks about 70 kilos, we'll give her 14 mils of the ketamine, and then all of the rock.
Daz and Lee will assist. Normally, this would be done in hospital.
So the plan A is going to intubate her. If that doesn't work, we might reventilate her and then do another tube.
Dr. Chris wants to make sure they have all eventualities covered. If something goes wrong and they can't intubate her normally, the team need to know what to do instantly.
If we can't oxygenate or ventilate, we're going to put the eye gel in. If that fails, we're going to do basic airway manoeuvres. If that fails, we're going to go to front of neck access, and she's got decent landmarks. OK? Is everyone happy with that?
First, they will send Janet gently off to sleep.
Janet, just keep your arms still for me, Janet. Relax, Janet. Relax. You're all right. Janet.
It's all right, my love.
It's all right. It's going to get better in a minute, all right? We're giving you something now that's going to start helping. All right, you're going to start getting sleepy in a minute, Janet. Just 30 seconds. Arms just relaxed.
The drugs are taking effect. Now it's time to put a plastic tube down her windpipe to make sure her airway stays open.
Ski the epiglottis. I can see the back of the cord's got a grade 1 view. Bougie. Gone through the cords, tube on. Okay, tube's going down. So that's 100. I have the tube going down. 1, 2, 3 to go through the cords. Bougie out, please. Take it to 22. Cuff up, please. Thank you.
The intention is to allow Janet's brain to rest.
So I've got end tidal. Al, can you have a listen to the chest?
Daz is just doing it now.
Oh, Daz, perfect. Thank you, Daz.
Yeah, good air entry, both lung bases, mate.
OK, good. Okay. Come off, Mills. Al, can you give me a hand just to put that tube in?
What do you want, mate?
Just that tube tied just there.
This bag will keep her alive until she can be put on a ventilator in hospital.
She was a reduced GCS we got here, a bit fighter, combative, so all we're doing is basically put her to sleep and just sort of dampen everything down, keep her nice and settled a while, and she goes through the CT scanner.
Right, has everyone got a bit? Yeah. Okay, on lift, ready, set, move.
Probably one of the busiest periods on the roads this time of year, people to and fro and buying last minute Christmas presents. Obviously got to visit relatives and stuff like that, so one quite a remote section of the road out here at the moment, poorly lit, and it's on quite a bad bend, so Mad Friday's not lived up to its reputation today.
We just have to raise her up a tiny bit and we'll just go really steady. Just Andy, just give us a shout if you need to stop with that because we'll have to pass it in. So just slide it really slowly. Keep sliding. Is she clear? Yes.
Janet is going to be flown 30 miles to the major trauma centre at Hull Royal Infirmary.
Hello, it's Chris here with Doctor with Helimed 98. Can I give you a trauma pre-alert, please? I've got a 6-year-old female who, at approximately 16:45, was a driver of a small hatchback who collided with a tanker. She was initially unconscious. She's got a head injury, query chest, query pelvis. She's had an RSI and ETA is 20 minutes.
The team are heading east over the Christmas traffic. Janet's crash isn't an unusual incident at this festive time of year.
It's Mad Friday and the roads are pretty busy because people have finished work, maybe going away to see loved ones, maybe doing the last runs for some shopping before the shops get very busy. And we tend to see a spike in road traffic collisions at this time of day, particularly as the sun goes down, it becomes dark and the roads are very busy. Okay, pre-landing checks.
Chris and his patient are now on final approach to the landing pad. She's going straight to resus.
This is Janet, who at 16:30 was the driver of a small little hatchback which crashed with a tanker HGV. She was trapped in the sea, query loss of consciousness. There's some reports that before she crashed she may have clenched her chest, and this may be a medical episode.
Okay. It is, once they have done their job of stabilization and they're headed on the way to the hospital, they will then communicate by radio, typically with either a OLMC, online medical control, who is a physician typically a younger ER doc or whatever is kind of like stuck in the radio room, or they'll talk to, if it's the EMTs, typically they will talk to a charge nurse. In the emergency department, there's typically a registered nurse. Typically they're in charge of either the trauma team or they're in charge of the acute side, the more critical side of the emergency department. So they tend to be the boss, and they tend to decide where people need to go based on the triaging decisions. And what the medics say or what the EMTs say then decides where this patient will go, based on severity and interaction between the nurse and the paramedics or EMTs, bringing Janie in with her apparently mild TBI, but there will be other assessments. All right, so once they'll oftentimes decide, okay, yeah, we'll put them in acute for an assessment by an emergency physician. All right, so an emergency physician, emergency medicine is it's a field that's been around since about 1985 is when it was established as a field. And what it is internal medicine, but with a focus on critical patients, more critical patients. And they have to be a jack of all trades, an ER doc, master of none. You know, they know all the different like internal medicine areas and some trauma and cardiac and neuro and endo and, you know, orthopedics and all that other good stuff. But they are not super in-depth. They then would call on specialists to push this from there. So here is a video of typically what happens for a minor TBI coming in and what kind of things that a emergency physician would be looking for.
A teenage boy is being rushed to St. George's after being struck by a car.
The impact of being hit by a car against such a vulnerable thing like the human body, you know, that's such a massive thing. Pretty much any part of the body could be injured.
16-year-old pedestrian versus car, bullseye the windscreen.
When we use the term bullseye, it usually means that the head has hit the windscreen and it's caused the windscreen to smash. Then I know that there's a significant amount of force, and that makes me worried that there may be a significant head injury.
Anyway, my name's Reece. I'm the boss doctor. All right, just work.
It's just a bit of a shock.
Yeah, of course. All right.
You need to just totally examine your head to toe, basically, and just make sure you've not done anything, okay?
In terms of imaging, I think we probably should.
if the brain gets damaged, and that causes bleeding or bruising around the brain, and that's the thing that we're worried about. Unfortunately, a CT scan, it doesn't go without any risks. It's a dose of radiation. And to a young child or a young adult, if I choose to do a CT scan, it's because I'm concerned that there's internal injury.
Wow, it's a mad whopper, isn't it?
Yeah, got a good egg.
Doctors now have the full report of Benj's CT scan and X-rays.
He's had a good whack. That's lovely. Thank you. Hey, Benj. Now, this is your pelvis. That looks great.
Great.
Great. Yeah. And then we're going to look at your chest. Oh, yeah. You don't give me much time, do you?
Yeah, you want answers, don't you, Ben?
It's good. You're keeping me on my toes. I like
Yeah.
it. Looks normal. That's for good.
That's good. That's good, Ben.
We've seen the CT scan of your head. Is it good? Yeah, it's good.
Oh, that's good.
Your heart rate's on the faster side, but I think that may be because you're a bit of a worrier, yeah.
We see people sort of at probably maybe their most challenging times in their life. And when things maybe start to fall apart for people, it's usually when people learn what's important. And a lot of these stories and a lot of these patients sit with us and stay with us, and that has a massive impact on our lives and the way that we work.
Okay, so they will be looking for signs, as you could tell from what this young doctor was looking at, that require either potentially a consult from like neurosurgery, orthopedics, cardiac, because most TBI patients also have other traumas referred to as polytrauma, and we'll get into that when we talk about what happens to our friend Dick, who has a serious TBI. But with Janie, she's going to be most likely cleared, and they follow a set of evidence-based standards to determine whether you need, for example, a CT scan. Here is one of those standard protocols that they can look to make the decision whether somebody needs an emergent CT scan, because you really don't want to expose somebody to x-rays more than you have to, and a CT scanner is nothing but a fancy x-ray machine. But it gives you the view of the brain, a more holistic view of the brain. If you meet the criteria, if you have, for example, raccoon's eyes, which is like a very black and blue mark under here, or battle sign, black and blue mark behind your ears, or you're bleeding out of your nose, or you've got clear fluid coming out your nose, your ears after an accident, this might be a sign of a skull fracture. And with skull fractures, that's a warning sign. Or you may have a depressed skull fracture or raised skull fracture. Other signs that they're looking for, you may have changes in blood pressure, heart rate. We're not going to get into Cushing's triad. We're not going to get into any of those kind of things. But these are some of the warning signs that, hey, this patient needs a CT scan. They also are looking for other clinical signs that we talked about elsewhere. For example, did they throw up a bunch of times, dizziness, very much the severe concussion signs, warranting a CT scan. These have been researched pretty thoroughly. And so if you tip that and it's like, uh-oh, we need to then do a CT scan and perhaps consult with neurosurgery. But usually, if you don't have those kind of signs as indicated by the study, if Janie doesn't show any of those, then what will happen is they'll either say, well, gee, we can watch her for a couple of hours, maybe 6 hours here in observation in an area set aside to monitor patients to see maybe she was feeling tired or dizzy, and we just want to make sure she's okay. Then they'll assign an emergency nurse who has, again, training in the same way, in that they have their masters or jacks of all trades, masters of none. They know neuro and they know, endocrinology, cardiology, the different disciplines. That's what I did for a while. and keep an eye on a patient with an MTBI to see, are they getting sleepy, are they throwing up, are they getting... If they're not, then the patient is then sent home. They're told, keep an eye on this. If anything crops up, come back. And, it's like they may be given fluids if they need them, some pain meds if they need it, and they're told, check with your doctor. They're given a set of instructions, what to do, and then told maybe in a week or two, or symptoms come back, otherwise see your doctor in 2 weeks. But we know that with MTBI that sometimes there can still be long-term effects, but the emergency room is concerned with imminent neurosurgical threats, things where you need to be cut. Okay, so if you don't show those kind of danger signs and you show that you're not deteriorating, oftentimes then you're sent home. And one of the problems is that patients usually don't follow up. And this can lead to permanent effects. Remember, just because you're cleared in the ED doesn't mean you don't have brain injury. It just means that there's nothing we can do for you there in the ED. And that maybe you need to follow up with a neurologist, a neuropsychologist, a endocrinologist, or some other medical professional. But right now we're talking about, the initial trauma process. And we could talk about some of the other stuff later. All right. So if, on the other hand, Janie is deteriorating or she's showing other signs and symptoms, or if the CT came back positive, if there's, for example, edema, if there's signs of a bleed, if there are signs of, for example, that she's got a tear in a blood vessel, any of these things, then the next step is to consult neurosurgery. And it falls to the neurosurgeon to make a decision. Is it bad enough to take them upstairs to the operating room and to do, different procedures? Here's a little video of the kind of things that a neurosurgeon is worried about and the kind of decisions that a neurosurgeon would have to make.
What do we want to do? We want to relieve raised ICP. So these are goals of surgery. Relieve ICP. So in blast injuries and high velocity injuries, that's early decompressive craniectomy, and that's really where the improved outcomes have come from. Evacuate an intracerebral hemorrhage and put a ventricular drain into control and monitor pressure. We want to prevent infection by debriding the wound and giving antibiotics. We want to prevent CSF from leaking out by repairing the dura. We want to treat vascular injuries, and that can be either open by clipping or occluding the vessel or via endovascular means. And we want to restore cosmesis and the integrity of the skull, and that can be either by plating fractures at the time or potentially doing a cranioplasty, fixing the skull at a later date. So as I said, if pressure's raised, the general rule these days is go early and go big. So a large decompressive craniectomy, and the outcomes for this seem to be significantly better than historical controls. We remove a hematoma, mass lesion, debride, devitalize tissue. You often need a multidisciplinary team depending on where the penetration's coming from, so you might need max facs or plastics or head and neck surgeons. Remove easily accessed foreign material to reduce infection, repair vascular injuries. For the most part, if something is deep or eloquent, we will leave it. So deep-seated foreign bodies, we won't go chasing because there's no benefit in doing that and only damage. We try and get watertight dural closure, which can require grafting. There's a tendency towards replacing bone unless it's really, really grossly contaminated to sort of save them another operation later on. I've got to say, if there's any concern about infection, I tend to leave it out because these people are critically ill. The last thing they need is an infection now, and it's not a big deal to go and give them a plate later on. We'll jump that in the interest of time. Infection's a big thing. It can happen to any of the basic components, the bone, the brain, the meninges, the ventricles. Obviously, the level of contamination is important and the time to treatment. So you really want to get on to operating on these people as soon as you can. If it communicates with a sinus, that's bad news. If there's a CSF leak, that's bad news. Also, what the actual object is. So wood has a lot of organisms on it and tends to have a high infection rate. Pseudoaneurysms I mentioned before, that's where the wall of the vessel is damaged and it forms an outpouching. And these can sometimes go away, but sometimes they can rupture years later and cause catastrophic hemorrhage. So it's something that we will look at. If we've got concerns, we might get an interval angiogram about a week later and then look at how we can treat those. We'll skip that. This is cranioplasty, so depending on the extent of the deficit that you've got to fill, typically what we'll do is we'll get a custom-made prosthesis that fills the hole. That's based on a CT scan. In young kids, these are not so good, and you might have to take off a bit of their skull from somewhere else and split it in half.
So this is what their focus is on. So based on the research studies, then it kind of becomes more like a primary neurosurgical concern. Remember how I said the ED doc can consult with different people. And if it's not as much of a neurosurgical concern, if watchful waiting, the patient would be admitted, Janie would be admitted to watch. But if it is a neurosurgical problem, then it gets handed off to the neurosurgeons who will perform the appropriate procedures, and the patient then will go to the intensive care unit, surgical intensive care unit, or neuro ICU. These are called by a lot of different names, where they will be monitored by a ICU nurse, as well as working with what's called an intensivist. The physician there is who's in charge of monitoring the patients after neurosurgery, or if they need to be watched. The intensivist is usually either an anesthesiologist or a pulmonologist, a respiratory doctor, who has a fellowship, which is training beyond the residency. Residency is where they learn their skills to be a physician. Med school, then go to residency. And then after that, if you want, many times they'll go to get their fellowship, which is typically a year or two of extra training in a very focused area within your specialty. That's your fellowship. And to be an intensivist, you usually are either an anesthesiologist who's completed an anesthesiology residency and then taken an intensivist fellowship. So for an extra year, you'll go through extra training in the ICU and how to take care of ICU patients. Or if you're a pulmonologist, a breathing doctor, respiratory doctor, you'll do your residency in respiratory care, and then you will take a fellowship in being an intensivist. Those are the doctors who take care of the patients who are in the ICU. They know what conditions can crop up in the ICU. They can prescribe the appropriate meds for patients who are unstable, and they care for them while they're up there. They may be assisted by a nurse practitioner who is a specialist in ICU care, or physician assistants, PACs, certified physician assistants, who are experts in the ICU and taking care of you there. And then they'll often work with an ICU nurse who is an expert nurse in working with patients in the ICU. What makes it an intensive care unit is that the nurse assigned there typically only has one patient or two at most, and they take care of patients using advanced technology. The patients there typically are on a ventilator, a machine that helps them breathe. They may be on an ECMO machine, which actually oxygenates the blood and pulls out CO2. It's basically a small heart-lung machine, and it also can circulate the blood. This is not as common. More typically, the patient is on a ventilator. They are receiving multiple IV drips to keep them hydrated, to maintain their blood pressure. Remember, I talked about pressors earlier. They may be on sedating medications. Pentobarbital is commonly used. They may be on, as I said, a lot of pain meds to control pain, anti-inflammatory medications to keep swelling down, antibiotics to fight infection, because that's a high risk after surgery, especially if you have a traumatic brain injury. You want to avoid sepsis and other things like that. Steroids as anti-inflammatories. Just a lot of different kind of meds that they would receive. Things for electrolyte balance. They may be receiving parenteral nutrition, so they may be receiving nutrition through a special line. They'll have arterial lines in many cases. They may receive blood. They may be on a dialysis machine in some cases to step up for kidney function, because a lot of patients have kidney, liver problems while they're up there because of the strain on the body. And if they have polytrauma, like I said, multiple traumatic injuries, they may need that. Like I said, the ICU nurse monitoring all these life functions and communicates with the intensivist for making adjustments and medications that may apply. There are other medications too, ones to keep brain swelling down, to control edema. They may have an ICP bolt placed. Speaking of ICP bolts, here's a video of one being placed.
Wipe the frontal area 3 times from the center to the periphery with an antiseptic solution. Then, place a sterile fenestrated drape over the head. Larger sterile drapes may also be used, but follow local guidelines. Raise a bleb with local anesthetic. Make a short 5mm linear stab incision. Use of a retractor is usually unnecessary. Ask an assistant to secure the patient's head. Place the drill perpendicular to the skull and turn the handle clockwise. Do not lean on the drill. You will usually be able to feel the drill bit penetrate the hard outer cortex, the soft central medulla, and the hard inner cortex. Place the bolt in position perpendicular to the skull and turn it clockwise, usually 9 half turns until it is secure. Loosen the cap of the bolt by turning the adapter counterclockwise and make a puncture in the dura using the dural puncture stellette. Cerebral spinal fluid may be visible at this point. Switch on the ICP transducer. Place the ICP sensor in sterile water and ask an assistant to connect the sensor to the transducer. Ask the assistant to calibrate the transducer and record the reference number. Insert the ICP sensor through the bolt to the desired depth, which is often approximately 15mm into the cranium, and then secure the sensor in the bolt by turning the adapter clockwise. When a strain gauge is used, a bend may be placed in the sensor at the desired depth, but other types of sensors should not be kinked. Dress the wound site using antiseptic soaked gauze. You may place a purse string suture, which can aid in wound closure after the bolt is removed. Hemorrhage can occur at any stage of the procedure.
This is typically done in the ICU, although it can be done in the emergency department, or in the ICU, I apologize, in the ICU. So that's typically, and as the patient comes out of their state of unconscious, their coma, that's something else. They'll monitor the patient in the coma. I do include that. They'll have devices that they may have placed in the head and elsewhere to see their level of awareness. They'll go out for imaging to see whether they are starting to wake up or not. If they're still in a long-term coma, then they may be sent to a long-term care facility, an LTAC, which is an acute care facility where they have acute care nurses and can handle these different things, but it's also got some characteristics of a nursing home because these patients are likely to take much longer to wake up. And it's up to the intensivist and the nurses and any therapists that come in, because some patients also receive PT and OT while they're in the ICU for their care for brain injury. So, that kind of thing. Or they may be having problems waking up. If they're there for a long time, they may receive medications to help wake them up. There are certain hospitals that have what are called disorders of consciousness programs. And these are aimed at helping the patient awaken. Doesn't work for everybody. There are a lot of people it doesn't work for, but this is something fairly new. As the patient wakes up, they may be sent to down to other floors, or they may be sent to acute rehabilitation. This is typical for, the more serious kind of TBIs. But if you don't need to worry about neurosurgery at all, and you're not going to follow this path, then then you're likely to just be sent out, and then it is up to the neurologist, your PCP or whoever's following you to decide whether you need outpatient rehabilitation. And a minor TBI, mild TBI so-called, You may benefit by having physical therapy, occupational therapy, long-term speech and language pathology. These are specialist therapists who are trained to help you regain skills that may be impaired or damaged because of a traumatic brain injury. You may work with a neuropsychologist, a psychologist who is specially trained in using standardized test instruments to determine whether you have neurological impairment and what kind of therapy, what kind of brain-related therapy might help you. Cognitive therapy, working on improving thinking, attention, memory, emotional function, behavioral function, those kind of things to return to as normal as you're able. We've talked about neuropsychology before. They often communicate with a neurologist and work on a diagnosis, things like that, and they may do the cognitive therapy themselves. But oftentimes that's up to the speech and language pathologist. All right. And then that is, like I said, typically what would happen if you had a milder TBI. You likely would not go through the surgical and ICU phases unless there is a bleeder. And yes, some people with an MTBI are more serious than it would appear, and they do need the neurosurgery. They do end up needing to go through the hospital, and many with an MTBI, even those who don't, still need outpatient therapy. Let's talk about Nick. He's riding, his bike. He's on his way to work or whatever. He gets hit by, a truck. In his case, somebody calls 911. He's knocked out unconscious, and he's serious. Again, the same thing happens with the dispatcher, but they'll talk to this other person, and so they'll ask questions. They'll still triage, and they'll decide, we need paramedics. Now, having been a medic myself, based on what we hear from the dispatcher, we may decide to call for an air ambulance. These are staffed differently and they come out of typically level 1 or level 2 trauma centers, which are the most advanced type of trauma care centers. A trauma center is a general type hospital, but it specializes in taking care of patients who have physical trauma, polytrauma. And I don't mean emotional trauma, I mean a blow to the head, the spine, the body. And they have surgeons that have specialized in trauma. A trauma surgeon residency is typically 6 to 7 years after the 4 years of med school. It is a long and rigorous training, and they are jacks of all trades in surgery, traumatic surgery. So they can fix all different kinds of things. They're not neurosurgeons, they're not orthopedic surgeons, they're not cardiothoracic surgeons, but they are jacks of all these different trades. And they head the team. Okay, we'll get to that in a moment. So usually an air ambulance is dispatched from a level 1 or level 2 trauma center to go help take care of these. An air ambulance is often staffed by a very experienced paramedic and a very experienced flight nurse, or sometimes a flight physician. I'm showing one from the United Kingdom again, a video from there.
Becky and the team are heading out to take over care of the patient from a land crew.
Clipped by the wing mirror, look at the car, wing mirror and bonnet.
The crash has closed a main road from York to the coast.
Hiya, I'm Becky, this is Kit.
How are you doing?
Yeah, better than this lady by the looks of things.
Yeah, Sylvia has been hit by a car going at 40 miles an hour. She was crossing the junction there, so and she was hit on left-sided, top to toe. She's cerebrally irritated. Left pupil larger than the other.
75-year-old Sylvia Dalton has a major head injury and appears to be losing blood internally. She was returning to her motorhome with her husband when it happened.
I'm Becky, I'm one of the doctors from the helicopter. Because of what's happened to her and the way she is, she's looked like she's got some nasty injuries to her chest and things. She's not breathing particularly well. We're going to pop her off to sleep, and then we're going to take her in the helicopter to Leeds so that she goes to the right place as soon as we can, OK?
Dr. Becky and the team need to act quickly if Sylvia is to survive. They're going to put Sylvia into an induced coma.
There's no room in back of that ambulance, there's lots of people in. So what we're going to do is bring her outside, form an RSA out here, and then fly her to Leeds from here.
Her chest injury means Sylvia's not absorbing oxygen properly.
Sylvia, do you know where you are?
On an aeroplane.
You're not on an aeroplane, lovely. You're in an ambulance. I know you're hurting, darling. I'm sorry. We're going to make that better very shortly.
Sylvia, we've just got a little mask for you. Okay, it's just some oxygen. There we go. I'm sorry. I don't know.
Outside, Matt's preparing to anaesthetise Sylvia, a procedure medics call an RSI.
She's going to need a thoracostomy as soon as she's asleep. She's got a big flail on the left.
Got that left in there.
Yep.
Pouch. There and there. Do you want some syringes out or have you enough?
I've got enough, thank you.
Blood leaking into Sylvia's chest is crushing one of her lungs. Once she's asleep, they will cut an incision in the side of her chest to relieve the pressure.
Let's get a blood pressure cuff on her. Let's get her out and get her off to sleep. I think that's where we need to go, really.
The temperature is plunging. It's already -1 Celsius. It's going to make their job much harder.
Once she's out, her body temperature will drop dramatically, so we need to work really quickly in this sleeping bag onto the aircraft and sort of do that really fast. We don't want her to lose body temperature, so yeah, it's not just about putting her to sleep, it's also about keeping her warm. We need to be slick at this, yeah.
Blood pressure last systolic was 120. She's just oxygenating really badly with SATs of 90.
Anaesthetising patients in the street is always a tricky procedure. But with little light, temperatures dropping and Sylvia's condition getting worse, the next few minutes will require total concentration.
So, potentially quite a dangerous procedure. So the plan is, we'll unsecure her. Are you happy to do mils?
As soon as she's asleep, they'll operate to ease her breathing.
Right, is that connected to high flow and turned on? Lovely. I'm going to swap the oxygen then and we'll pre-oxygenate with this as best.
Is she definitely getting a left thoracostomy, Becky?
She is definitely getting a left-sided thoracostomy.
In that case, it's all right. I'll get ready for that, Matt. It's on the other side there.
Kit, are you happy to do cricoid thought during the RSI, please? Lovely. Right, can you come and open her collar and identify your landmarks, please?
It's a complex procedure involving a precise combination of drugs.
She's dropped her blood pressure a wee bit, so we'll just pull back on the fentanyl a little bit. Matt, I can't really reach the cannula. Are you happy to do the drugs? Yep. So will you go for 150 of fentanyl, which is 3 mils? You're okay, lovely. Just going off to sleep now. Well done. Well done, Sylvia.
She's now deeply unconscious. Time to intubate her and take over her breathing.
Let's go for it. She's not breathing.
Becky must slide a tube down her windpipe.
Well, that's a minute since the last of the rock now.
Intubating her will allow her brain to rest and allow the team to get more oxygen into her lungs.
So I've got a grade 1 view. Tubes through the cords, bougie out, please.
Bougie out.
Scope out.
A bag will now be used to manually fill her lungs with air.
Squeeze the bag, please, Matt. Tubes misting. We've got CO2. Super, thank you.
Happy for cricoid off.
Happy for cricoid to come off.
And already she seems to be improving.
SATs are coming back up. CO2's 4.9, 4.5.
And then there's a problem.
Auscultate her chest for me, please, Kit.
Yep.
Because I've got SATs at persistently low 80s.
The level of oxygen in her blood is getting lower.
Quiet air entry.
The reason is unclear.
Good air entry. Not a lot on the left there at all, Becky.
Right, okay, can you do that left-sided thoracostomy now, please?
Unless they can restore oxygen flow to her brain, Sylvia will die. This was already going to be a tricky procedure. Sylvia's survival now depends on the skills of Dr. Becky and the team.
Lovely, her tachycardia is immediately reduced.
Yeah, you feel lung now.
Lovely. Good, well done.
Okay.
Good work.
That's good.
Now the race is on to fly Sylvia to surgeons.
So we're going to take this lady over to Leeds, the trauma centre. She's obviously got some really significant injuries. The traffic's really bad. We're quite a long way away, so we're going to fly her in the helicopter. And instead of it taking upwards of an hour, it's probably going to take 10-15 minutes to get her there, which might be quite significant for her. She's obviously got some really quite serious injuries, so the
The trauma specialists at Leeds are probably the best people to look after her at the minute.
But Sylvia's condition is once again getting worse.
So sats have dropped a wee bit.
Do you want a finger in again?
Yeah, please.
Her chest was crushed by the impact. It looks like broken bone fragments have punctured blood vessels.
There's a broken rib just at the base of the hole. So.
There's lung.
There's lung? Excellent. That's good.
Yeah, you can also feel a pericardium, so let's not stick our fingers in it too often. Pop the back arm back in. Let's go.
Yeah, thanks.
Might just have to accept the fact that our sats aren't brilliant.
They're going to make a dash for Leeds. They're transferring Sylvia into the helicopter. But now there's another problem.
I'm not happy. Sats are dropping. Something's changed. CO2's okay, but despite ventilating.
So, shall I start at her and have a quick listen?
Yes.
Kit's listening to the sound of her breathing, in the hope it will give them a clue.
Lost all monitoring. Is there still oxygen in that cylinder? I think there is. I can see the dial.
Yes.
What are we doing? Why are the sats low? Why are they not? She's ventilating as best we can. We've got oxygen. She's got a significant chest injury, we know that.
She's got better air entry on that side after you've moved the tube.
Okay.
So do you think the tube migrated a bit?
I think the tube had migrated, yeah. So I've pulled the tube back a wee bit. Both sides of her chest are going up and down. We've got a good CO2 trace, so we did have a minute ago.
It's all back.
Okay, let's try and see if we can get our sats back up above 90 and then we can start moving again. Just be really careful with that fact that we don't bash this tube. Come on. Come on. Can anyone think of anything I'm not thinking of?
The team are running out of ideas. Then Kit comes up with a theory.
She's got a really weak radial on this side.
Just wonder.
So your BP. Do you want to start some
I
blood?
wonder if we give us... that's exactly my thought. Should we give her some blood?
They're going to give her an emergency transfusion to raise her blood pressure.
I know it's not ideal, but ultimately she's not going to do well if she stays here, is she?
Kit's alerting Pilot Lee. Only speed can save Sylvia.
Patient's deteriorated. We've just started blood, so we can delayed on scene. Making our way around now.
Emergency ONEG allocated to us. Date tested 29th of December.
Good up.
Donor blood is being pumped into their patient. And it looks like it's working.
Okay, I think improving her blood pressure is improving her sats, because tramadol and her sats are coming back up.
So it's all blood related?
I think this is all hypoperfusion. I think this is volume related, so I think blood is exactly the right thing to be doing.
That's running nicely.
Lovely.
Now that Sylvia's condition is more stable, the team need to quickly get her to the specialist teams in Leeds. She is still bleeding internally.
So this lady's blood pressure dropped quite significantly, and we think it's related to severe bleeding, potentially from her pelvis or inside the tummy, but also possibly the chest. It's difficult to know at the minute. We've given her some blood, which has started to bring her blood pressure back up a little bit, and she's started to improve slightly, but she's still very, very ill.
Okay, what you just saw there, lady being, she had head injuries, she needed chest tubes, she needed, a lot of advanced intervention. And they could do things like the beginning of what a trauma center can do for you. Chest tubes, anesthetics, intubation, a whole lot of different things. And whether it's a flight physician or flight nurse that leads the team, there are people who are very experienced and have been working in the ICU or been working, in the emergency department for years. And they're a lot freer because many of them have been working in the ED, the ICU, have been doing surgery, whatever, for 15, 20 years, and they are old hands at this. They just have to learn like helicopter handling procedures and, like what to do if it goes down or whatever. But they are, Johnny on the spot with all kinds of stuff. And this is why they can do a lot more of this. And they have close communications with the trauma team. So, but I'm not going to deny that it is really expensive if you need to basically fly in a flying trauma bay, because that's exactly what this is. And helicopter obviously moves a heck of a lot faster to one of these very high level care centers. All right, you've seen this if you've watched TV. You've seen scenes that look like this. Talk about confusion, right? This is a trauma bay. But despite the fact it looks confusing, it's organized, actually, very organized. Here are the different people that staff a trauma bay. A trauma bay is very specialized. At the left, kind of back to the side of the patient, is usually the trauma surgeon, the leader. And usually it's either the neurosurgeon or the trauma surgeon, depending on the nature. If it's polytrauma, again, many different kinds of injuries, not just head, but spine and shoulders and abdomen and cardiac, and the trauma surgeon is lead. If it is mainly neurosurgeon is lead. And obviously if it's mainly orthopedic, it's the orthopedic surgeon, whoever's going to do the cutting. But trauma surgeon typically. And they don't do much hands-on until it starts getting complicated. Something else to tell you, the paramedic or the flight doc or the flight nurse will tell the team first, and usually one person talks at a time. One person speaks back, and there's somebody taking notes at the feet, the scribe. Usually it's a nurse scribe, but there are, there are physician scribes and nurse scribe, so. They will tell them, but the medic or nurse or doc will tell the team, everybody there, what's going on, how severe, what they saw, what treatments they've done, all that stuff, what their assessment is. Then the trauma surgeon will start giving instructions, and the team then, it's a closed loop. You can't have like 20 people talking. They may tell the senior resident in trauma what, it's like, hey, start looking for other injuries, other things like that. I may tell one of the trauma nurses, hey, start an IV. I need you to, start administering pressors. Their drug, their levels are low, for their blood pressure's low. I need, you to start pushing, the dopamine, or I want you to push, whatever. They may say, it's like, hey, to the lab who's over there, I need you to, did you bring, do you have all the units of O that you could get for this patient? They're, bleeding. It's like, it's time to, asking radiology, and it's a back and forth. And as they go through, and then, but you can see from that picture that, but it's all organized, and they will assess the patient, looking for any hidden injuries, any other problems that may be present. And they will do quick x-rays. As you notice, they're wearing lead. They'll do a series of fast x-rays as well as a search up and down. And then they'll make the decision, hey, do we have to cut? And again, it's kind of like with the CT scan, everything else. Some trauma centers have the CT right there in the room, and they could just toss them in and just close off the one side, just take a quick CT image. And then they will either start to cut right there. They have surgical sets in the trauma bay, and they can do some of the basic stuff right there, the surgical interventions right there. Do they need chest tubes? Do they need crike? Do they need, it's like maybe an amputation is necessary. Maybe they want to put the ICP bolt in right away if they decide they don't have to. Then it's time to, the anesthesiologist will have them intubated, who's at the head. Then they'll take them off. Oftentimes the OR is like right next door. The trauma center I worked at had the OR like right there. And they'll go right into the dedicated, this is something else that's important. They have in a level 1 trauma center and a level 2, they've got dedicated ORs all the time, ready to go for trauma patients immediately. And they'll also have specialist surgeons, neurosurgeons, orthopedic surgeons, and they'll have hand surgeons, they'll have burn specialists, they'll have all these different kinds of docs dedicated right away and within a certain time. The more generalized type of surgeons, they'll have 24 hours a day, 7 days a week, 365 a year at a high level 1 or 2 level trauma center. For the 3, they may have to be there within 30 minutes, but these docs are ready to cut right away, because as we say, have always said in emergency medicine, they need bright lights and cold steel to fix trauma. You can't futz around with them out there. They need to be in the OR. They need to have their bleeding corrected. They need to have corrections for surgery. All right, so let's talk specifically about neurosurgery. What are the kind of things that a neurosurgeon can do? What are some of the options, especially early on? You saw the video from before. Let's take a look at specific procedures. Well, one of these procedures is craniotomy, where you literally will remove a piece of the skull, either a hemi or a bifrontal, or you take a large piece of the skull off in case there is edema, swelling. That's this.
This is Ricardo Komatar, Christopher Kellner, and Mark Otten, in conjunction with Sander Connolly and Guy McCann, leading you through a bilateral frontotemporal decompressive craniectomy. The patient is positioned supine with their head neutral and elevated on a cerebellar headrest. Perioperative antibiotics are administered. In the majority of cases, the entire head is shaved. Skin incision is marked from zygoma to zygoma, just behind the coronal suture. The surgical field is then prepped and draped in usual fashion, including sterile towels, Ioban, a white sponge, and craniotomy drape. The forehead down to the eyebrows must be included in the surgical field. A linear incision is made from superior temporal line to superior temporal line. If pericranium is being harvested, care must be taken not to cut through this layer and stay just deep to the galea. Rainy clips are placed to reduce scalp bleeding. The incision is then completed as marked towards bilateral zygomatic arches. The skin and soft tissue from the superior temporal line to the zygomatic arch must be carefully incised and divided down to the temporalis fascia so as to preserve the superficial temporal artery. Again, Rainy clips are applied to reduce scalp bleeding. Temporalis fascia and muscle, the scalp and temporalis are retracted forward to expose the frontal skull. Perforating towel clamps and rubber bands attached to a laylabar apply tension and maintain exposure. The surgeon must always be cognizant of external pressure on the orbits and should take measures to minimize potential complications by raising the laylabar and removing unnecessary drapes in that region. If pericranium is being harvested, this layer is left down while the scalp is being retracted forward, using blunt dissection and Metzenbaum scissors to separate the layers. Once the scalp is fully retracted forward, the pericranium is sharply cut posteriorly and along the superior temporal lines laterally, then mobilized as an intact sheet with an anterior vascularized pedicle. The pericranial graft is protected with wet white sponges until needed later in the case. The planned craniotomy is outlined, with 2 slots across the superior sagittal sinus, one low and just above the orbital region, one just behind the coronal suture. Burr holes are also placed bilaterally, low in the temporal region, where the bone is thinnest, and at the keyhole. A high-speed drill is then used to perform the craniotomy. The bone flap is carefully elevated to preserve dural integrity. Care must be taken to not injure the superior sagittal sinus. Gel foam and cottonoids are placed over the sinus. The craniotomy is then expanded as needed using a combination of pneumatic drill and rongeur instruments. Particular attention must be paid to both the temporal and frontal regions, where maximal decompression down to the floor of the middle fossa and near the roof of the orbits are critical. Once sufficient bone has been removed, the edges are waxed, dural tenting sutures are placed, and meticulous hemostasis is obtained. The dura is opened on each side in front of any major venous complex, using a 4-0 silk suture and a Levin blade. The durotomy is extended in a stellate fashion and barrel staved to the bone edges with long straight scissors, cautiously so as to not injure the cortical surface or vasculature. The dura must be opened sufficiently right to the edge of the superior sagittal sinus in order to expose the midline and falx cerebri intradurally. The superior sagittal sinus is tied off with double 2-0 silk sutures. The sinus and falx are then coagulated and divided with bipolar cautery and long straight scissors. Closure of a bilateral frontotemporal decompressive craniectomy begins after meticulous intracranial hemostasis has been obtained. At this point, the dural edges are grossly reapproximated with strips of dural substitute below. The pericranial graft, if harvested, may be used as a supplement. Any discrete bleeding on the dural surface is handled with bipolar cautery. Epidural and sinus bleeding are stopped with a combination of flow seal, gel foam, and pressure. Drains and ICP monitors may be placed at this time and tunneled out posteriorly and laterally. The towel clips are removed and muscular bleeding is identified and precisely cauterized. The scalp is closed with 2-0 vicryl stitches at the galeal level and staples to reapproximate the skin edges. The wound is properly dressed with bacitracin ointment, sterile gauze, and tegaderms.
As you see, this is mainly done to take care of, brain swelling, but it can also be done to take care of if there is bleeding. And, excuse me, when there's bleeding, when there's an epidural, subdural hematoma, whether there is subarachnoid hematoma, there's intraparenchymal, wherever there's blood that shouldn't be, you'll have to do a craniotomy to be effective. Sure, they might drill burr holes or whatever, which is using a special kind of drill to, and then to evacuate. But we found that doing craniotomy is usually the most effective way. And then you evacuate the blood and do a wash down, wash it out, and, seal off the bleeder. Here's an example of taking care of an epidural hematoma. yes, unfortunately, you're going to see some of these kind of things. Other kind of concerns do include washing out to prevent sepsis, cleaning out, a lot of bleeding, things like that, and closing off the... Finally, after the patient has been in the ICU for a while or is ready to, as they're getting ready to go, you want to do a cranioplasty, which is basically to reshape and reform the skull again. You've got different options. For this kind of surgery, you either use a piece of the skull that you took out. You can either store it on facility or actually store it within the abdomen to keep it alive. That's surgeon's choice for the circumstances, but you know, they may take pieces of crushed up skull and reform it. They may use plastic or titanium, again, or take the original piece and just cut and reshape it. Cranioplasty is necessary not only cosmetically, but because obviously you can't have exposed brain. They'll often do, well, they'll do duroplasty, which is basically shape, cut the original dura matter and, you know, reseal that as well. That they'll do after they've fixed the bleeder. They also are going to be looking for risks of arteries having weakened walls. When you have a severe TBI, like our buddy Dick did, you are at an increased risk for aneurysm, and the walls, the blood vessels have weakened. And so they're going to look to cauterize anything like that that they may see. And it's something to monitor. Not all patients have this, of course, but some are at increased risk for this. And if you have the genetic weaknesses or you have connective tissue disease or anything like that, you're at a higher risk. And so that's the kind of thing that a surgeon may try to remediate surgically while they're inside. And as I said, finally, it's like just generally a wrap up. So those are the kinds of things that a neurosurgeon would try to take care of. Those are the procedures for them. In the neuro ICU, I had mentioned all the different, the different procedures and things like that for the neuro ICU. A severely traumatically brain injured patient is in for a long road for recovery. The neuro ICU supports them, but it may take days, weeks, months, or even a year for them to fully come out, depending on a lot of factors. The genetics plays a role, environment, what happened, the kind of energy applied, the kinds of injuries. They may slowly move down. They may move to then an intermediate care unit where some of the features of the ICU unit are still present. Or maybe they happen to wake up quickly. After that, then they will go to an acute inpatient rehabilitation unit, either in that hospital with a trauma unit, or they'll go to a separate hospital, an acute care rehabilitation hospital, where they will work with all different kinds of therapists. As I mentioned a little bit before, there speech and language pathos who also do a lot of cognitive therapy. It's important to remember that cognitive therapy, there are no specialist cognitive therapists. There is no credential for it. It doesn't exist for brain injury cognitive therapy. It doesn't exist. So speech and language pathologists who help work on speech skills, because if you have aphasia, trouble talking, or trouble understanding language generally. Physical therapists who have a doctorate in physical therapy. Occupational therapists who work more with like day-to-day cooking, cleaning, working on your fine motor skills. Maybe if you do repair, whatever, stuff like that, those kind of finer motor skills in your hands and, those kind of things. You may work with educators to help reteach some kind of cognitive kind of skills. Neuropsychologists, talked about them. They do a lot of, they're more your general experts in higher cognitive function. They'll work with the neurologists who are experts in they're generalists in brain disorders. That's what they are. Usually in charge of an acute care rehab hospital is what's called a physiatrist or a physical medicine doctor. And they are experts in the process of rehabilitation. They prescribe the rehab program, they design it and work with the therapists to come up with a good plan for rehabilitating patients to get them as back to normal as they can. Here is a video from a young man who went through a pediatric acute care rehabilitation program. I do want to let you know that we do not endorse any particular hospital or anything like that here. I'm just showing you this, and this is how it goes, how it works.
My name is Ryan Boyd. I'm 8 years old and I'm going into 4th grade.
Ultimately, Ryan is a kid who just loves to have fun and he sees adventure everywhere he goes. He loves magic. He loves tumbling, playing piano, loves SpongeBob, Star Wars, loves to laugh. And he's like I said, he's a typical little boy, but then he's more than that. I'm Dawn Boyd. I'm Ryan's mom, and he was a patient at Brooks Rehabilitation Hospital. It was a Sunday morning. Our spring break was almost over, and the kids had spent the night with their grandparents who live next door. We live on 5 acres of land, so we have golf carts and a gator that we drive back and forth. He went out with his papa to get the mail, and it was kind of chilly that morning, and he wrapped a sheet around himself. And when he reached out to get the mail, the sheet dropped and got caught under the tire of the gator and just pulled him. And he couldn't stop it. He couldn't break his fall. He just fell immediately and hit his head on the one little piece of concrete that's out there. So we called 911, and they sent out the ambulance, and then they airlifted him to Arnold Palmer Hospital for Children in Orlando. So So we finally got to see him, and they told us he had a traumatic brain injury and he was unconscious. He was in a coma for about 5 days, and they started weaning him off and bringing him back. But when he came back, he didn't just wake up. He opened his eyes, but he wasn't there yet.
For patients like Ryan who have survived severe traumatic brain injuries, it is not unusual for medically induced comas to be performed and for patients to wake up slowly following the removal of that sedation. For parents and family members and friends who see this, it's pretty distressing, and they are constantly grappling with the question of, will they return? Will they be themselves again? When will they return?
I basically pulled a doctor aside and said, where would you send your child? And they said Brooks. And even though Brooks was actually further from us, we wanted what was best for Ryan. We needed him to be back, the Ryan that we know. So we took a ambulance ride to Jacksonville, and the next day they start doing evaluations on him. Brooks was the right place to be for Ryan and for us, because we felt like family there. It really was my home for 7 weeks and his. And everybody just really rallied behind Ryan. Baptism told him every day, I love you, Ryan. And he'd say, or he'd whisper when he finally talked, I love you. And it became a home for us. It was really great that they listened to what Ryan liked and tailored some things, around him. And even his therapist knew what he liked and used that in his therapy. His cognitive therapist knew that he liked magic, so she started bringing magic tricks from home for him to work on and, for some of his skills, which was great. And he knew some of them, that he remembered. And even though he wasn't really talking at this point still, he could do the trick. One day while we were up there early in May, it was Star Wars Day, and they had arranged for a group of stormtroopers to come and visit, and so they knew Ryan was a fan of Star Wars, so they made sure that they made a special visit to him. They brought him some trading cards and a framed poster from one of the movies, and made a big deal of him, and I had his dad bring up his Jedi robe so that he would be dressed up for the occasion. It's gonna forever be special. The nurses and doctors at Arnold Palmer saved his life, but the people at Brooks helped Ryan find his magic again. It's a place that all kids can find their magic again. Thank you for giving me back my son, because I had lost hope when I had gotten to Brooks. I didn't know that if it was possible. And the therapist rallied behind him and around our family and made us feel like their family, and they will always be in our hearts. And we will forever be grateful to them.
To find a good rehab program, acute care, you look for one that is accredited. That's CARF accredited, the accreditation for rehab facilities. If you find this seal, you know you found a good one, because getting that credential is hard. It's really hard to get that. So if you've got that, it's probably a good program. All right, I'm not gonna Now it doesn't mean if they don't have it, they're not good. There are a lot of good programs that don't have it, because, like I said, that's hard. That's for those of you, it's like getting your Eagle Scout or whatever. I don't know. It's like really hard. All right. So after you complete your program, then there's outpatient rehab. Okay, outpatient rehab is like part-time. You may go in there 2-3 times a day, whatever, or weekend times, and they taper it over time to just like polish off those certain skills, or speech, language, patho, or if you had a less severe injury, you just may get this kind of rehab. And it just works on skill development until you've either used up your a rehab allocation from your insurance, which is a problem, or until you are ready to go home. And then you will encounter other folks if, you have a good rehab program. Occupational therapists on the one side who will help you, or not occupational, sorry, vocational therapists. You'll encounter when you go home, if you've had a good program, vocational therapist. The Office of Vocational Rehabilitation is a state program that helps you find accommodations and things you can do to find a job or to work a job that works within the range of the disabilities, especially if you have had moderate or severe TBI, and find and provide for what you need, funding and support, things like that. Okay. Even if you've had mild TBI and have persistent symptoms, talk with your neurologist, find a neuropsychologist, talk to your PCP. They really don't have a lot of training in TBI, but you may be lucky and find one who has that as an interest. The Office of Vocational Rehabilitation helps you get back to work or go to school if you need it. They may provide funds for your education. Many states have the TBI waiver, which is funding for people with traumatic brain injury. And there's the ABI waiver, which provides for other kinds of acquired brain injury. Then there are community reintegration programs. There are support and help groups. Friends with Brain Injury is all about that. We have educational videos and we try to help people. So basically that is a quick view. You may not think it's so quick, but a quick view of the process from injury to return to the community. I have one about kids where we look at the legal rights that kids have under the Rehabilitation Act, which you also have right to under the Rehabilitation Act, certain protections in your job and other things like that, and the Americans with Disabilities Act. But I've got other people who can talk about that. But just know you've got certain rights in the community too, and with employment. But I hope you found this helpful. Please share this video with others who you think may benefit. Like, subscribe, don't forget the bell. And hope you see you next time. And please, any comments below. Have a good day. Bye.